Welcome to our panel, Healthy Homes, Healthier Children, on Children's Environmental Health Day. We are very pleased that City Council issued a proclamation acknowledging today as Children's Environmental Health Day in Philadelphia, and also noting the establishment of our Philadelphia Regional Center for Children's Environmental Health. We hope that these kinds of activities will stimulate more collaborative and just great work on behalf of children's environmental health in the region. And hopefully some of you will participate with us in these efforts. I'm Dr. Marilyn Howarth, the Deputy Director of the Philadelphia Regional Center for Children's Environmental Health, a collaborative center of the University of Pennsylvania's Perelman School of Medicine and the Children's Hospital of Philadelphia. Through partnerships with area universities and community organizations, we aim to translate proven strategies and identify new ones to improve children's environmental health. My work focuses on environmental justice and reduction in environmental health disparities. I've worked with communities, researchers, regulators, and legislators on environmental problems, including climate change, lead exposure, air pollution, legacy pollution, water quality, and flooding issues, among others. I'm joined today by two colleagues doing very important work in this space. Dr. Jessica Rice is an assistant professor in the Division of Pediatric Pulmonology and Sleep Medicine at Children's Hospital. She completed her residency in pediatrics at St. Christopher's Hospital for Children and then moved to Baltimore for a fellowship training at Johns Hopkins, where she stayed as a faculty there until 2021. At that time, she came back to Philadelphia. Jessica's research interests are in modifiable risk factors for pediatric lung disease, and she currently has an NIEHS funding to measure indoor air pollution and respiratory health outcomes in infants with chronic lung disease of prematurity. She'll share with us the clinical perspective on housing and health and the research questions that are still unanswered. Alon Abramson is the director of residential programs at the Philadelphia Energy Authority, where he oversees the Solarize Philly program and the innovative Built to Last program that delivers whole home repairs. All of Alon's programmatic work has a central focus on equitable access to stable, affordable housing and leveraging clean energy to provide long-term utility affordability. Alon has a master's in environmental engineering, and he built his early career experience at the University of Pennsylvania, analyzing best practices in programs and policies for improving energy performance in cities across the globe. Let me begin by setting the context, connecting housing and health. I'd first like to begin with our land acknowledgement, recognizing in particular during this week of Indigenous Peoples Day. So let's talk a little bit about poor health risks of poor housing conditions. Housing in the United States has been underappreciated as a determinant of health. I can tell you when I was in medical school, we were not trained on how to ask the right questions about housing quality and poor housing conditions. And more importantly, doctors today don't know the availability of resources that may be in the community and how to link their patients to those resources. And so they tend to not ask the questions for which they have no tenable options. And so we really would need the benefit of linkages with our community partners to make inroads in this important social determinant. So how can we develop a comprehensive home-based prevention or early remediation strategy that can really improve health in this space? I think we need to go back to understand the context of how we got to this place of poor housing. And this, although I'm focusing here on Philadelphia, I think what I'm talking about is so relevant to many other places across this country. Redlining, or the systematic disadvantage of Black communities, is really to blame here. In the early part of the 20th century, these maps were created for banks and mortgage institutions, and identified, as you can see, these red neighborhoods. They were the neighborhoods that were considered troubled, and in fact, they were the Black neighborhoods. These were places where our lenders would not give mortgages, and more importantly, to current times, continue to actually have decreased home remediation loans, those kinds of homeowners loans that people rely on to fix their roofs and do other kinds of maintenance activities. And so the greatest poverty, as you can see from this map, correlates quite well in these redlined neighborhoods. And so we have African American populations concentrated in neighborhoods of poverty. Deteriorated housing is a result of poverty. If you can't get the loan to actually fix your home, these compounded deteriorations lead to deteriorated housing. And deteriorated housing itself is a unique risk factor for poor health. And these are some of the connections that we can draw. Many of our older homes contain asbestos, and dilapidated, deteriorating asbestos releases asbestos into the air and can increase risk for lung cancer and mesothelioma in those homes. Similarly, deteriorated housing leads to peeling lead paint, and many homes, in particular in our older cities, have many coats of lead paint. And the deterioration of that paint can lead to lead dust in homes and lead paint chips themselves, both a risk for children as well as pets in homes. In addition, water intrusion from a leaky roof or from pipes that have burst lead to health impacts in a number of ways. They themselves deteriorate building materials, but also lead to mold. Mold that can be insidious behind walls, as well as right out up front and center in walls immediately accessible to building occupants. And mold itself can increase asthma risk, and many, in particular Northeast cities, have elevated asthma risks in their population. Philadelphia certainly has a high disparity of elevated incidence of asthma in children and adult populations. Deteriorated housing also causes pest infestation, rodents, cockroaches, mice, and these kinds of rodent and other pest infestations are, distinctly unpleasant to people. And so what do? They go and find pesticides that they sometimes over apply for themselves in their homes, and sometimes bring in applicators that may or may not apply them safely. But pesticide overexposure itself has been associated with a variety of health risks, including increased risk for cancer. And combining all of these together increases health disparities in a very impactful way. Now add to these the social disparities or the social determinants of racism, poverty, and poor or inadequate education. And you can see why certain populations are at increased risk and more vulnerable to these kinds of poor housing quality insults. Starting with lead, you can see on these maps, these zip codes that are the darkest green show the zip codes with the highest poverty. The zip codes on the right map with the darkest blue show the zip codes with the highest, the oldest homes in Philadelphia. And the larger the gold circle, the higher the incidence of elevated blood lead levels. And so you can see poverty and age of housing being very significant risk factors in Philadelphia for elevated blood lead risk. But paint is not the only pathway of exposure for elevated lead in children. Drinking water, another important housing risk, contains lead when housing has lead service lines. Many housing units in Philadelphia and a number of other older cities have these lead service lines. In addition, the solder that are used in the pipes, as well as brass fixtures, can add lead to that mix. And not to mention the soil that may be around homes that can be tracked inside homes and add to the dust. Remedies, home remedies that are imported and not subject to FDA scrutiny can have been shown to have increased elevations of lead, as well as a number of other sources like toys. Probably the most important health impact for lead exposure is in the cognitive and neurologic realm. And so we see delayed development, reduced IQ scores, and decreased educational performance, largely due to poor attention span, direct learning difficulties, irritability, and symptoms of ADHD. Violent and aggressive behavior has also been seen in both children and carried into adolescence and adulthood. These cognitive impacts are really lifelong in their impact. In addition to cognitive impacts, higher blood lead levels have been associated with colic and with kidney problems, as well as coma and death in children. Fortunately, we rarely see that now in the United States, but still certainly at risk when we have uncontrolled lead exposure. Even adults have impacts. Adults that were impacted as children have now cognitive problems as adults, and it may be associated with dementia. When adults get exposed, often in an occupational setting, they can have encephalopathy and peripheral neuropathy in hands and feet, among a number of other health impacts. And going back to children, the CDC now identifies that children with blood lead levels as low as 3.5 or greater are at risk for lead poisoning and lead effects. And this lowered reference level has not yet been used in our surveillance in public health. The latest information available in Pennsylvania uses 5 micrograms per deciliter as the trigger. And in that circumstance in 2020, we found over 4,300 children under the age of 6 with elevated blood lead levels. It is predicted that there will be twice as many children the next time this report comes out using that new CDC level of 3.5. Asthma is another important health impact of poor housing. And as you can see, remembering the previous maps I showed you, the map here of asthma hospitalization rates has clustered in those areas of poverty that we see impacting lead as well. And our Hispanic and Black populations are at increased risk of asthma hospitalizations in Philadelphia. Asthma triggers in homes can be many, and we've mentioned some of them already with the pests. Saliva, feces, and proteins from body parts are really important contributors to these asthma triggers, and allergy is also exacerbated, as well as mold. Mold proteins can become entrained in air, and when homes are swept or dusted, they can be resuspended and important asthma triggers. So in conclusion, mitigating health hazards in homes is really the frontier of improving health and reducing health disparities in terms of our indoor air and indoor environment. I would urge you to follow us on Twitter and LinkedIn.
I just get started. The EPA has concluded that fine particle pollution is a serious health threat based on its association with multiple adverse health effects. Increased exposure to PM 2.5 has been linked to reduced fetal growth with prenatal exposure, respiratory-related infant mortality. The EPA has concluded that fine particle pollution is a serious health threat, and I went through this. Respiratory-related infant mortality, wheezing in infancy, development of asthma in children, slowed lung function growth, increased asthma symptoms and rescue medication use, and more severe asthma exacerbations. Indoor air pollution is made up of particulate matter that is suspended in the air and originates from indoor sources such as dust, mold, bacteria, tobacco smoke, gas cooking, wood-burning fireplaces, and cleaning activities, as well as outdoor sources like pollen, combustion from motor vehicles, and power plants. Particle size determines deposition location in the respiratory tract. While particles less than 10 micrometers in diameter, PM10, can be inhaled, fine particles less than 2.5 micrometers, PM2.5, are deposited deep in the alveoli, leading to health problems. Fine particulate matter is a commonly used marker of indoor environmental tobacco smoke exposure, and although it is not specific to cigarette smoke, other combustible sources typically contribute less to indoor PM2.5 than tobacco smoke when smoking is present. The burden of air pollution is not evenly shared. Pollution sources tend to be located near disadvantaged communities, increasing exposure to harmful pollutants. Non-white populations, especially Blacks, are at higher risk for particle pollution. People of color are more likely to live in counties with higher levels of pollution, as Marilyn has attributed to, and many inner city homes are old and in poor repair with water damage, mold contamination, infestations, and smokers. Next. Previous studies by my research mentors at Johns Hopkins have demonstrated that inner city Baltimore homes, and likely similar in Philadelphia, have high levels of indoor air pollution, and these levels are higher than simultaneously measured ambient and suburban home concentrations, and often exceed EPA standards for annual ambient PM2.5 exposure. Other studies in US cities have evaluated indoor air pollution where there is a smoker and found that levels of PM2.5 can be increased by as much as 14 to 35 micrograms when compared to non-smoking homes. The NAEPP 2020 focused updates to the asthma management guidelines included a review of indoor allergen mitigation. The expert panel recommends that clinicians consider allergen testing when appropriate and feasible before committing individuals to specific allergen mitigation strategies that may be burdensome, expensive, or difficult to use or maintain. For those with asthma who are not allergic to indoor substances, environmental interventions in the home are not recommended. For individuals with asthma and an allergy to a specific indoor substance, using multiple rather than single strategies to reduce the allergen is recommended. An example of a multi-component intervention is the use of maybe 3 single interventions like an air purifier, impermeable pillow and mattress covers, and a HEPA vacuum cleaner. Integrated pest management in the home is recommended for those who are allergic and exposed to cockroaches or rodents. Again, it's important to consider the air quality inside the home since people spend most of their time indoors. The best way to decrease risk of indoor air pollution is to control or eliminate sources of pollutants and to ventilate the home with clean outdoor air. Other potential interventions include venting all gas appliances to the outside, avoiding wood fires in your house, enforcing a home and car smoking ban, and providing cessation counseling or FDA-approved cessation medications to parents or caregivers who smoke. If these measures are insufficient, an air cleaning device may be useful, and the EPA has published a document with guidance around recommending air cleaners in the home, shown here on the top right. Most portable air cleaners can filter particles from the air, and some air cleaners filter both particles and gases. The longer the air cleaner runs, the more air it filters. Note, though, that filtration does not replace the need for controlling pollutants, removing them, and ventilation. Multiple studies have found improvements in one or more allergy and/or asthma symptoms with the use of HEPA air cleaners, but the studies do not always show major improvements in health outcomes, and they do not show improvements in all symptoms. Other barriers to recommending air cleaners include the cost of replacing filters, electricity use, noise, and potentially odors, since air cleaning devices designed for particle removals are incapable of controlling gases. The odor and many of the gas phase pollutants from tobacco smoke will still remain. Finally, portable room air cleaners can be used to clean the air in a single room, but they are not intended for whole house filtration. Clinicians should advise patients with asthma to monitor outdoor pollution levels and move activities and exercise indoors when there are air quality alerts. Patients who have asthma that is triggered by pollen allergies should stay indoors as much as possible during the season when their asthma tends to flare and keep their windows closed while using an indoor air conditioner. In 2018, the CDC's National Asthma Control Program published a document which presented evidence-based strategies to improve asthma control and reduce healthcare costs. Home visits for trigger reduction and asthma self-management education were included as one strategy. Home visits can reveal barriers to patient engagement, adherence, or asthma control that can't fully be appreciated in the outpatient ED or hospital setting, including housing conditions and social stressors. Asthma self-management education and multi-trigger, multi-component interventions, which are appropriate for the type and location of housing, are a core element of successful home-based strategies. A variety of providers can effectively deliver home visits, including nurses, respiratory therapists, certified asthma educators, and trained community health workers. Many studies, including a systematic review and multiple randomized control trials, have shown that home visits can improve asthma control and medication adherence while reducing ED visits, hospitalizations, and missed work or school days. And many U.S. programs have shown that home visits can reduce healthcare costs. Home improvement incentives such as loans, grants, or tax credits can help low-income families improve their home's energy efficiency or reduce or remove health hazards such as mold, moisture, or pests. These home improvement programs can be implemented at the local, state, or federal levels. Numerous U.S. communities, states, and other nations have implemented comprehensive smoke-free policies which prohibit smoking in all indoor spaces. Smoke-free policies for residences can be voluntary or mandatory, and individuals, families, or property owners can implement these policies. Studies have shown that improving the homes of low-income individuals or families through home weatherization assistance programs can reduce asthma-related ED visits, healthcare costs, and missed school days. And this will be a nice segue to Alon's talk.
Thank you to the center for having me on this at this event, and thank you especially to Marilyn for the great introduction, and to Jessica for kind of building on that, talking about the real solutions that we are seeing, practitioners advocating for, to help children who are suffering from asthma and other environmental exposure related health issues. I'm going to build on that even further and talk about what we're doing in Philadelphia to basically take all this kind of knowledge base that healthcare researchers and practitioners have basically been advocating for, and putting that into practice here in the city to basically help low-income households improve their health outcomes. I'm going to talk about Built to Last. This is a program, a platform to restore safe, healthy, and affordable housing. Again, really primarily serving low, moderate income households. Again, I'm Alon Abramson. I'm the Director of Residential Programs at the Energy Authority. And just to kind of get us started, for those who don't know, the Energy Authority is a government agency here in Philly that was created in 2010, and really with the goal of using energy as a tool for impact. So we look to use energy for economic development, job creation, poverty alleviation, and improving public health, all of which is encompassed in the Built to Last program. Just to kind of add to the context that Marilyn and Jessica already provided, we know that Philadelphia is a poor city. Poverty rate hovers right around 25%. That includes 1 in every 3 children in the city living in poverty. Marilyn already discussed this, that poor housing conditions contribute to negative health outcomes, but also to energy insecurity. Philadelphia also has the unfortunate designation of having the 4th highest rate of asthma in the US. And then on the energy side, which of course we're very interested in at the Energy Authority, we have our lowest income residents, those earning 30% of area median income, are paying over 18% of their income for utilities that we describe as energy burden. And then over 50% of all African-American households, regardless of income, and over 30% of all renters are facing energy insecurity at least once a year. Energy insecurity being kind of foregoing food or medicine to be able to pay for utilities, and basically being in the situation where you're constantly facing utility shutoffs, or potential utility shutoffs. We have a plethora of existing home repair programs in the city, and utility assistance programs, all of which are bringing money to these issues, but very few homeowners are able to get all the needed improvements. That's what really prompted us to create the Built to Last program, which is a holistic housing solution for Philly. We are using Built to Last to coordinate resources in order to stabilize homes and make them affordable, healthy, and safe. Through the program, we're aiming to complete 10,000 holistic home repairs in the city by 2033. In doing so, reduce the number of ER and urgent care visits for children with asthma, reduce trip and fall injuries in the home, offer health counseling services like the ones that Jessica was describing, bring energy burden down below 6%, which is what is kind of described as the threshold of a higher energy burden. Improve climate resilience, in particular adding air conditioning, and very importantly for us, creating local well-paying jobs to do this work. Sorry. So what does a whole home, kind of holistic home improvement look like? We're talking about basic systems, improving, repairing roofs, electrical, plumbing, HVAC systems, dealing with structural issues, energy efficiency, of course, weatherizing the homes, doing insulation, lighting, efficient windows and doors, dealing with water as well. And then health and safety is a really important piece of this and is kind of our top priority with Built to Last. So dealing again with trip and fall hazards, excess moisture, lead paint, mold, pests through integrated pest management. And we're really excited to be offering kind of these other measures, putting solar on properties wherever that's feasible, doing electrification, so moving properties from fossil fuel heating or cooking, and then moving that over to electric, and especially doing that and pairing that with solar, which helps us really reduce long-term energy costs for that household. And then we just talk about that as fuel switching. So the program's up and running. We're currently completing our initial 50-home pilot. I'll talk a little bit about kind of where we are there. And we, in this current fiscal year, we'll be completing this pilot, also looking to complete another set of 50 homes. And then we're starting to scale up the program next year to 150 homes and then 250 homes. We've allocated through grants over $5 million in order to do this work. And we have a commitment with the Green and Healthy Homes Initiative and ProMedica Foundation to help us fund the first 1,000 homes of the program. And then we're going to be looking to healthcare, state government, federal government, local government, really funders to be able to keep this moving and build on this this momentum and do this in 10,000 homes. And we do also have some support from the state housing financing agency as well. I mentioned that we're doing our pilot right now. We have 50 homes that we're serving. 7 of them are currently doing assessments. So we're trying to figure out what the scope of work is going to be there. We're scheduling construction in another 13, and then the remaining 30 are either currently in construction or have completed their construction. So some of the numbers I'll show on the next slide are kind of representing mainly those 30 homes that are currently or have been constructed or repaired. And the map I'm showing here is the distribution of all of our 50 homes, which should look a lot like the maps that Marilyn was showing. The redlining map, the lead exposure map, the energy burden map, they are all the same map because there's the housing age map as well. It really does kind of show the correlation between housing condition, poverty, and these secondary outcomes. I'm showing here the energy burden and the census tract colors, and then the different dot sizes represent households that are accessing the city's basic systems repair program. So higher intensity sort of suggests that there's worse housing conditions in those areas. And we're really aligning pretty perfectly with these two conditions. So what have we been doing in Built to Last? We are performing weatherization in every project. We're addressing moisture, mold, lead, pests in these homes, restoring heating, plumbing, and electrical service. We're installing brand new bathrooms, oftentimes in kitchens. That's obviously improving hygiene, but also just basic access to housing services. Repairing stairs for accessibility, and also removing trip and fall hazards. Electrifying, as I described, the HVAC systems, water heaters, and stoves. And we are adding rooftop solar at the majority of homes, and we're particularly prioritizing homes with really high energy burdens. We see over 30% in some of our homes, as well as homes where we're doing that electrification work. So just some quick stats here. This is a program all about leveraging what's already out there. So each of these homes is getting about 4 existing services, basically all coordinated at the same time. We're spending over $40,000 per home And PEA itself is spending over $10,000 per home in order to fill the gaps that we're currently seeing from the existing service providers. And identifying those gaps, we're also then promoting additional funding, to come into the city to, address those in a more permanent way. And so far in these initial 30 something homes, we've spent about $1.5 million. So just a quick run through of some of what this work looks like. We're doing major bathroom repairs, as I mentioned. This is a before and after. Kind of hard to believe. Kitchens as well, so adding functional kitchens. We're doing stove replacements, as mentioned, so replacing non-functioning or semi-functioning stoves, often gas to electric. This is an induction stove and another induction stove here. We're doing knob and tube rewiring, typically to be able to access the attic so that we can insulate. Insulating an attic is a really, really big energy improvement measure. We are doing full HVAC replacements. Here we're taking a furnace and putting in a heat pump system, offering now air conditioning as well as heating in the home, and much more efficiently. We're doing moisture management. In this case, we are looking at residing the rear of the home where there's a lot of moisture entering. Same home, we're also doing window replacements, and this also has a heat pump system that was put in. We're doing indoor and outdoor stair improvements as well, which again is partly accessibility, but also a really big safety improvement for these households. So with that, I will stop sharing my screen. Really excited to have a conversation with all of you and look forward to your questions.
That's great. Thank you. Thank you both so much. Let me just go to the questions that we have in the chat so far. One comment that was made about the concern about the gas stoves with nitrogen dioxides and ultrafine particulates being introduced into homes. And I noticed, Alon, you said that one of the changes you're making is going to induction stoves. And was that a health-based implementation?
Yes, there's there's a dual consideration there. One is health, and as Mitch pointed out in the chat, there's a lot of studies now showing that there's NOx exposure for stoves, especially when there's poor ventilation, which is in most homes. So that's definitely a consideration. And the other is we're often doing this where there's no operable stove at all. So we're kind of providing that service, and in that case, we want to move as much over to electric as we can. And in some cases, we're actually able to get the entire home off of gas, right? And the stove is one of the last measures that we need to kind of move over to gas. And then that from a cost perspective means, they don't have to pay the PGW connection fee anymore. The whole home is electric. And then we've also added solar there. So it's really a cost measure for us as well.
Got it. That makes sense. I also see a question having to do with whether or not the Built to Last program would be applicable to home childcare providers who have their businesses in their home.
Right now, we're not serving small businesses. I think that's a great point, though. And I think this exact set of measures, the work that we're doing here isn't at all exclusively kind of reserved for single family homes. So that's who we're serving, primarily because there's a lot of existing dollars, and existing programs that already do that work, right? So we're just kind of cobbling them together. Mm-hmm. I think that there really is a need and should be kind of a push for doing this work in, these centers that are, kind of touching so many children's lives. So.
And just one more question from the chat, and then we'll move to some others. What type of assessment are you using to determine the scope of work for the contractors?
Sure. Yeah, we're taking, I guess you can kind of think of it as like an augmented weatherization assessment. So our program partner is the Energy Coordinating Agency, which is a weatherization service provider for the city. And so we've basically taken that work where, they're already looking at, where can we plug holes in the home essentially, and adding on to that a checklist of health measures that they need to be looking out for.
Okay, I'm gonna move to a couple of other questions that we had before. So Dr. Rice, do you think that people should use air purifiers, and if so, What advice can you give families about selecting air purifiers for their home?
The use of air purifiers is not, quite in the guidelines yet as a single, in combination with a multi component intervention to reduce and improve air quality. It can be used. I would refer you to this document. I can put a link in the chat for the EPA guide to air cleaners in your home because it goes into specifics, but keeping in mind no air cleaner will eliminate all pollutants in your home. It doesn't replace source removal or good ventilation with clean outdoor air. And then keeping in mind all filters need to be regularly replaced because if the filter is dirty, it will not work. And then keeping in mind also referencing the air cleaner packaging that will indicate the clean air delivery rate or the CADR for removing 3 specific types of pollutants, tobacco smoke, dust, and pollen. These pollutants are used as examples to represent small, medium, and large size particles respectively. So to remove the smallest particles, choose a portable air cleaner that has a high CADR for tobacco smoke, which represents the smallest particles, and then the CADR should be large enough for the size of room that you want to use it in. So if you use one that's too small, that's not going to be effective either. And then of course, always avoiding a portable air cleaner that produces ozone. That's really important.
Great, thanks. There was a question that came in about screening for toxic metals. Should childhood screens include other toxic metals beside lead, such as arsenic or cadmium? There can be synergistic toxicity. I have thoughts about that, but I'm not a pediatrician, so I'm going to throw it to the pediatrician for the first comment. Dr. Rice?
That is a good question. I don't know that we are able to screen for those, but we know that exposure to some of these things can have effects probably on neurodevelopment, but I am not an expert in screening for toxic metals. So that is a good question.
I'm not aware that there have been any recommendations to screen for other heavy metals, except if there is some kind of unique circumstance. And in our industrial cities, there frequently are unique circumstances where you find a neighbor that was, really contaminated the soil, and we just became known or something like that. So I hope that physicians are asking those kinds of questions about their environmental circumstances that their patients are finding themselves in. But I don't have a basis to make a specific recommendation as a screening, more universally.
Thank you, Marilyn. I actually have a question for Alan and a question for Jessica Rice. So, Alan, my question to you is with 55 houses you're currently doing, how did you prioritize which ones to do? And also, if it's grant related, do you provide grant writing assistance to people that might have trouble making the application?
Got it. So great set of questions. The first 50 homes we recruited mostly through existing partnerships with the service providers themselves, 8 different services together. And so they already have an intake process and they are identifying clients themselves that exceed their own ability to serve. A good example of this is the Basic Systems Repair Program. They can do $25,000 of work in a home, but often they're encountering homes that need $35,000 of work. We can take that home, kind of parse out the needs there, and then have other partners contribute to that cost, and then kind of fill in the remainder with PEA dollars. So that's one of the approaches we took. We also worked with some community organizations, specifically the Hunting Park community group, and they were able to provide 10 referrals directly to us. So we're kind of trying a set of different approaches of how we recruit these folks. And the reality, Dr. Penning, is that there's so much of a need, right? We identified, somewhere around 60,000, households that probably fit into, what we're describing as this group of homeowners with older homes. that are low income, and it's just always going to be impossible to find like the ideal candidate. So we're just trying to do the best we can with a small pilot group. But to your second question, this is grant funded, but we're not asking for additional applications, right? If folks are eligible for the programs that we're cobbling together, essentially that's the qualifier itself. And so then we are just trying to do this as in as seamless a way as possible for those households. Right? So we're trying to make this like a single intake point, single application process, single home audit, and then a single kind of construction project. And so the homeowner doesn't necessarily know that there's 5 different programs serving them with PEA coming in as well. They just know that they've gotten a whole home construction project done.
So the homeowner cannot apply for themselves, is that correct?
They can apply. So as we move into, from this kind of pilot program into, the more scaled up version, we'll have it more of like a, go visit your local community agency and, you should be able to kind of enter the program more organically.
Okay, thank you.
Yeah, sure.
So Jessica, I enjoyed your talk a lot. I was wondering, you made the point that smoking in the home was one of the major sources of pollution. So what do you do about secondhand smoke and third-hand smoke? And this also goes into the area of getting individuals who are smoking in the house to actually cessate smoking. So there's a number of issues there. How do you deal with those?
That's a good. First of all, can you guys hear me? You can hear me. Okay. Avoiding the exposure, not having a home and car smoking ban is obviously the first recommendation. Difficult to implement, we realize. And then the third-hand smoke is all the surfaces. So upholstery, drapes, carpets, all have particles from the tobacco smoke in them. So regular cleaning, although that's not a perfect way either. And then indoor air cleaners, HEPA filters, can be used to reduce the particulate matter. If it's a particle HEPA filter, can significantly reduce PM 2.5 associated with tobacco smoke, but does not completely remove the exposure because it doesn't, unless it's a gas filter, it does not remove the gaseous phase. It does not reduce air nicotine, the gaseous phase, but even just reducing the PM 2.5 is thought to reduce some of the asthma symptoms or respiratory symptoms associated with that exposure. So it's better than nothing, but it's not a complete, removal of the exposure would be best.
So if you have a child that comes into your pediatric clinic with asthma and you find out the parents smoke, what do you tell the parents?
We try to tell them that, their child's symptoms, smoking is one of the, besides viral illnesses, is the largest trigger for their asthma symptoms if there's smoke exposure at home. And to avoid that the best as possible. Smoking always outside the home, changing clothes, brushing teeth, washing hands when you come back inside the home, having a smoking jacket or some things, but never smoking inside the home, even if the child is not there, even if you're smoking near an open window, even if you smoke in your car, that's your own car, but if the child goes in that car, those are all ways your child will be exposed later. And I think people don't also appreciate the third-hand smoking exposure, like we smoke in the room, but an hour later the kid comes home. It's in the curtains, the drapes, the sofa, the carpet. Kids are crawling on the floor. They're more exposed laying on the couch. So we try to tell them to not smoke in the home ever. Having this home and car smoking ban is the most important thing. I haven't recommended too much using air purifiers in the home because they are expensive. Some people say they have them. I'm not sure if they have humidifiers or purifiers because that gets a little bit confusing. But if they can use one in the room where they spend the most amount of time, in the child's bedroom or in the living room, that would be helpful also.
The evidence that indoor air quality is an exacerbator of asthma is overwhelming. The issue that I would like you to address is we're very much, especially the EPA these days, in a cost-benefit analysis. So do we have good data from your interventions about how we've reduced the healthcare load?
So we know that this is kind of a piece of data that's, I wouldn't say missing, but definitely not robust enough. So part of our evaluation kind of protocol and plan is to do more kind of longitudinal review of outcomes for the households we're treating. That's part of our intention with the partnership with the ProMedica Foundation, is to be able to kind of do that health-related outcomes evaluation. But we realize that that's also kind of a longer-term thing, right? Like you can't do an intervention and then know that there was an immediate effect, not necessarily. So that's our intent, and then to be able to kind of add a value to that, right? But there are, in the literature, we know that there are some kind of assumed values for these interventions and like kind of a societal reduction in asthma prevalence or ER visit incidence or whatever it is. So we're also undertaking kind of a separate effort to try to quantify any specific measure we're taking in the home, measure being kind of just the term of art of like any repair thing we're doing, try to attribute a cost, kind of a benefit to that measure. Typically this is done, but the Department of Energy does this already for weatherization. They're very, very focused on energy. We want to kind of take a step back and think not just about the energy implications, but also the health implications. And, there's some work that we're doing that even enables us to do any of that stuff, right? So we should attribute a value to that as well. So we're trying to be a little bit more holistic, even in how we think about, the initial cost and what that value is to that family.
Yeah, cost benefit analysis of air purifiers. That will be in if I do a trial with the air purifiers in the home. But I have not done that myself. I'm trying to find a paper that one of my colleagues wrote that I thought commented on that, and if I find it, I will put it in the chat. Because there has been some cost benefit analysis of like doing interventions, multi-pronged interventions, but.
And Dr. Penning, just to add on, we're also deploying air quality monitors in our homes and trying to do that as often as possible too, so we can show, kind of, before and after air quality level or, PM levels and other. I think we're looking at temperature, humidity, particulate matter, and maybe carbon dioxide or carbon monoxide, something like that. There's a small set of indicators that we're reviewing. So hopefully, we've got kind of the short-term piece that we can evaluate, and then we've got the longer horizon piece on outcomes.
Let me just jump to the chat, because I just wanted to mention that Lorna Rosenberg said that the PADEP has funding for nonprofits and schools for conduction stoves. And then there was a question, is the PA whole home repair bill slated to impact the Built to Last pilot?
We are waiting for the state. So this Whole Home Repair Act passed in the last legislative session. It's modeled off of Built to Last. So we really hope that we can, use some of that funding. It's $125 million for the state. So we're hoping we can take some of that funding, bring it into Philly and use it through Built to Last. But we're waiting right now for DCD of the state to write out the guidelines so we understand what that program looks like.
Another question was, have you had any issues with contractor capacity, especially finding ones with the proper certifications for, I'm thinking RRP certifications for just disturbing lead paint?
Yeah, no, it's a great question. Yes, of course, we are requiring that RRP certification, and a lot of contractors got it during the ARA days, basically during Obama's term, and then sort of let it lapse. And so now we're kind of working. Fortunately, ECA, who's one of our main partners, is a lead certifying, RRP certifying agency. So we can get these contractors back up to, at least to be certified. But typically they know the processes and they're doing lead safe work. But it's definitely a challenge.
And I will just say, just put in a plug for our work at the Center of Excellence in Environmental Toxicology. We have a policy initiative right now that we're trying to gather stakeholders around to require all contractors working in the city of Philadelphia to have RRP certification. So if there are any on the call who would like to join us in this effort, we welcome you. And we think that if all contractors were actually certified, many more people would be safer than they are right now, because we know there's a lot of work happening that is not being done in a safe way. How does the PEA share its activities with city agencies?
Yeah, it wasn't quite clear on that question, but so some of our partners are city agencies, and we we're trying to be as coordinated as we can, with every city agency that we can kind of find. you know, both on, I mean, this is becoming an even bigger imperative because of things like the Inflation Reduction Act and, you know, sort of making sure that there's a unified vision for how we, you know, are sort of climate ready and you know, using these federal and state dollars to the maximum advantage of Philadelphians. So we try to make sure that everybody, you know, all the city agencies are aware of our work and vice versa.
Hi, this is Brian out in Colorado. I just wanted to share some resources with people on this call. I put one in the chat. The National Center for Healthy Housing has actually done a cost benefit analysis and an outcomes analysis of the New York State Healthy Neighborhoods program. And we've actually used that to justify investment in an indoor air quality program in our jurisdiction. So I wanted to make sure people had access to those resources. I'll add their other URLs for their other assessments in the chat as well. But I already added the cost benefit one. It's been really helpful to us.
Great. Thanks so much, Brian. I'd like to thank our speakers for you know, they're sharing their expertise and their programs and their work with us.